This conference will now be recorded.
Well, good afternoon, everybody, and thank you for joining us today as we introduce you to the Lurie Children's team from the Division of Orthopedic Surgery and Sports Medicine. And for this session, I'm very excited to introduce you to Dr. Rebecca Carl. Today, she'll be discussing pediatric knee exams. But before we do, I would like to talk to you a little bit about the Division of Orthopedic Surgery and Sports Medicine. We are nationally ranked for by New U.S. News and World Report. We care for more than 30,000 children each year and providing a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders, and offer the only pediatric bone health program in Illinois. This is how we are able to recruit the finest specialists in the nation, such as Dr. Carl. The Knee Injury Prevention Program, also known as KIP, is a neuromuscular training program that is designed to reduce the risk of ACL injuries among female adolescent athletes. KIP for Coaches is a free online training program to help coaches reduce the risk of ACL tears and other lower extremity injuries in their athletes from ages 10 to 21. In KIP training, coaches learn how to lead their athletes through a 10-minute warm-up routine that includes strength training exercises, plyometrics, balance training, agility drills, and active stretching. Our clubfoot program is a comprehensive and multidisciplinary program for clubfoot, a congenital condition that can affect one or both feet in newborns. The concussion program is uniquely qualified to evaluate, manage, and treat concussions in children and adolescents. I would like to remind you that our new Skokie site is up and running. We have 20 specialties, including orthopedic surgery, sports medicine, and cast care services. Our sports medicine team is there 5 days a week, one of which is Dr. Carl. Dr. Carl is an attending physician here at Lurie Children's and is part of the Division of Orthopedic Surgery and Sports Medicine. She is an assistant professor of pediatrics at Northwestern University's Feinberg School of Medicine. She completed fellowships in both non-operative pediatric orthopedics and primary care sports medicine. Dr. Carl completed a master's degree in clinical investigation at Northwestern University. She directs the Northwestern University Lurie Children's Hospital Sports Medicine Fellowship and teaches at Northwestern's Feinberg School of Medicine. Her research project interest, it's kind of a tongue twister, include community engaged research, concussion education, and clubfoot. Before we get started with Dr. Carl, I'd just like to remind you that discussion questions are encouraged in our chat room, and we will get to those after her discussion. But without further ado, I'd like to introduce you to Dr. Rebecca Carl to discuss pediatric knee exams. Dr. Carl, take it away.
Great, thanks so much, Chad, and thanks to all of you for joining us today. I'm actually at our new Skokie clinic, and you can probably see a little bit of the background, which if you haven't had a chance to check out our new facility, please swing by, it's great. It's actually a really nice option during COVID because it's a really nice spread out layout and easy parking. So we've really been enjoying it here. So I wanted to do a little sort of, not exactly a workshop, but a case discussion, and I added some relevant physical exam to make it more workshop-like. So we'll be going through a few cases today. So the first case, this is an 11-year-old boy, and he presented to the sports medicine clinic with a 3-month history of knee pain. And when you ask him where the pain is, he locates it to the inferior aspect of the patella on the left knee. Oh, sorry, the right knee. And so this is you can see the little lightning bolt here is where he's indicating his pain. And he doesn't have any mechanical symptoms like catching or locking of the knee. He hasn't really noticed any swelling, and pain generally occurs when he's very active. And when you're doing your exam, the main thing that you notice is that when you push over the very bottom of the patella, the inferior pole, he reports tenderness at that location. And the remainder of the exam, including special tests to look at ligament instability, those are all normal. So just to review the anterior bony knee landmarks here, you can see number 1 is most people are familiar with this landmark, the tibial tubercle, and children who have Osgood-Schlatter are sore over the tibial tubercle. And then 2 is the patellar tendon, and 3 is the inferior pole of the patella. So he's tender, when you're really trying to distinguish, he's tender over 3. And this boy, actually, this is not a child that I would necessarily get radiographs for. I generally think of getting x-rays for a child who, certainly if a child has mechanical symptoms or swelling, we would get them if a child had a history of trauma. But this child does not have those things, but he actually came to our clinic with the radiographs. And so here are his AP radiographs, and I'll give everyone just a minute to look at them. And I looked at these.
Where am I supposed to see them? I can't see anything. I just see some of the other members.
Is anyone else having difficulty seeing the screen, the x-rays on the screen?
No, we see your screen just fine, Dr. Carl.
At the top of the screen, you can click view everyone and just view who's talking.
Yeah. I'll let others report on the technical aspects because I'm a bit of a Luddite. And can I ask I hear some phone ringing too, so if people don't mind muting, thanks. So these were, I looked at these AP radiographs and thought these were normal radiographs. You can see the physes are open, which we would expect in this 11-year-old boy. And then we also got a lateral, I should say he presented with his radiographs, and we also had available to us a lateral radiograph. I'm just good, I know that for many people are planning to watch this later, and in the interest of time, I'm not going to spend a lot of time in discussion, but if anyone wants to volunteer a thought about the x-ray, I'll give people a minute to weigh in. If not, I'll go ahead and just point out the finding that. So this was actually, I would actually read this as a negative radiograph. These are normal radiographs, but if you look closely, you can see a little bit of lucency at the inferior pole of the patella here. And this is actually a normal growth plate. And as it turned out, this boy had gotten bilateral films, even though the pain was on the right, and he had the exact same finding on the left side. And so this is a diagnosis that we don't necessarily need radiographs for, but we happen to have them. So I'm just going to challenge people. I'm not going to put anyone on the spot to weigh in, but of these 5, just kind of look through the list and think in your mind, commit, what do you think is the most likely diagnosis here for this child? And so I'm going to do the reveal, and the diagnosis here. This is Syndig-Larsen and Johansson syndrome. And this is a form of Syndig-Larsen-Johansson is a form of apophysitis, which is an irritation of a minor growth plate. It's very similar to Osgood-Schlatter. In fact, when I have residents coming through my clinic, I describe this as Osgood-Schlatter's little cousin, because this is almost identical in presentation to Osgood-Schlatter, and the treatment is the same. The only difference is that children tend to present a little bit younger. So Osgood-Schlatter is irritation of the tibial tubercle growth center, and Syndig-Larsen and Johansson syndrome is irritation of the inferior pole of the patella growth center. And we tend to see Osgood-Schlatter, and in girls we see it more around the ages of 12 and 13, and a little older, 14, 15 for boys, since boys grow later. Whereas Syndig-Larsen-Johansson we see usually in girls who are about 9 or 10, and boys who are closer to 11 and 12. So this is, if you were to like put a quarter over the front of the knee, one end of the quarter would touch the tibial tubercle, and one likely the inferior pole of the patella. So these are very close together. But just another thought. If you're seeing patients who are a little younger than your typical age group with Osgood-Schlatter, that you want to try and distinguish between those two diagnoses. So this next case, this is a 14-year-old who presented to the clinic with a history of bilateral anterior knee pain. And she also reported frequent clicking in the knee, although it didn't lock up on her or get stuck. And she reported that pain generally happened when she was sitting for prolonged periods, sometimes when she was going downstairs, and occasionally she had mild swelling. And one thing that I ask patients when they tell me they have swelling, I find it's a lot like bleeding, is that when you're a medical student, you learn that patients will describe bleeding as a lot more than it may actually be. So a patient might say it bled a ton, but actually it was 5 cc's. And that's similar to swelling. And so what I like to do is ask patients to describe the amount of swelling in relation to the size of a piece of fruit. So was it the size of a grape? Was it the size of a strawberry? Was it a watermelon? That would be more concerning, obviously. I don't know that I've ever seen maybe a miniature watermelon swelling, but not an actual large watermelon. But that's just a way that you can get young people to quantify for you. So she would say occasional mild swelling. It was one of those where the girl said, I think it swells a little, and the mom was saying, I'm not so sure. So and then she was indicating the area around, so hopefully everyone can see my arrow, the area around the kneecap here is the location of her pain, sort of diffusely. And when you looked at her on physical exam, her kneecap was tilted a little bit to the outside. So we call that lateral patellar tilt. And she was tender over the medial patellar facet. And I'm just going to show how to reach the patellar facet in a moment. And she had what we call a positive apprehension sign. So when you're moving around the kneecap, the facets describe the back parts of the patella where they meet the little, the patella sits in a pocket at the bottom of the femur, which we call the trochlear groove. And so there's little flat edges of the kneecap underneath, and those are called the facets. And that's just where they meet up with the femoral trochlea. And so what you can do is you can actually make sure that the patient has their knee extended and has a nice relaxed quad muscle, and you can move the kneecap back and forth and then try and reach under the knee. So if you're pushing the kneecap laterally, then on the lateral aspect, you can reach underneath the kneecap and rub, and then you push it medially and reach under the medial kneecap. So these are just two still pictures. And then here's a patient who had very hypermobile patella. So I'm just going to show this video. And you can see here, it's quite easy to move this patella. And we say that the patellas are hypermobile if they move more than a centimeter in each direction. So I'll play that just one more time. And you can see that is a bit more than a centimeter. So I would describe that for sure as hypermobile. And then the other thing, so this girl on exam had her patellas were a little hypermobile. And then she also had this specific sign that we often see in people with her diagnosis, and I'll show the video. So if you watch her kneecap,
come back down.
She bends
one more time.
Them, you can see that they kind of go up. Thanks. And then they go to the outside when she extends. So I'll play that one more time.
And come back down. One more time. Thanks.
And that pattern of motion, it looks like a letter. It looks like sort of an upside down letter J. The kneecaps move up and out. And so we call that a J sign, and that's a sign of patellar hypermobility. And then the last test that I mentioned is the patellar inhibition test. So this is where you hold down the patella and you ask the patient to contract their quad muscle. And if they don't know what that means, you can put your hand behind their knee, so between the table and their knee, and tell them to straighten their leg as hard as they can, like they're trying to crush your hand. For some reason, patients like the idea of hand crushing, and that should cause pain. Now, some people have a little bit of sensitivity with this test, so if it's only unilateral pain, I like to do it on the contralateral side as well. So graph, but this is a view called a merchant view, and you can see on this view the kneecaps really they do tilt off to the side, just like we notice clinically. Also, the trochlea, this little V-shaped area, is kind of shallow. So really, most people will have, it's kind of the shape of the trochlea, it's a spectrum, just like height. And so some people have a really nice deep trochlea, and the patella sits way deep in the trochlea and doesn't move too much, and other people have a shallow trochlea. And I would describe this as a very shallow trochlea. You can see that there's barely a V shape here for this is, it's more of a little sinusoidal wave than a V. So I have described the findings here. I would say that there's a lateral patellar tilt and a hypoplasia of the trochlea. So again, I'm going to ask people, and we won't have people weigh in, but we'll just have people look at the list and think about what they would put on their differential at the top of their differential diagnosis for this patient. And the diagnosis for this patient is patellofemoral syndrome. And I think of patellofemoral syndrome really as a spectrum. There's some people who have completely normal anatomy. They don't have a patellar tilt or hypermobile patellas, but they still get a little wobble of their kneecaps that can be irritating. At the other end of the spectrum, we have people who have very shallow trochleas and very loose ligaments around the knee, and they can even dislocate their patellas. And that can be its own sort of, that can cause other problems. But often there are people who, they don't have patellar dislocations, they just have a lot of motion of the patella. And the treatment for patellofemoral pain is to have patients do exercises that are aimed at pulling the kneecap to the inside. So strengthening muscles like the adductors and the hip and core muscles that can help anchor the kneecap to the inside, which is sort of the good position, because the kneecap, when it moves, it tends to shift to the outer position or laterally. So the other thing that can be helpful is having a patient wear a brace that stabilizes the patella, which we call a patellar stabilizing brace. And these come in all different shapes and flavors and sizes. The simplest brace would be a sleeve with a hole cut out for the knee. The advantage to that is that it's really low profile, and if a patient is having mild symptoms, they often will like that better. But if they're having they're more symptomatic, or that's not holding them, or they have really loose kneecaps, then using a brace that has a nice bolster around the kneecap can be really helpful. And those are the braces we tend to dispense in clinic. They tend to be a little bit bulkier, so sometimes patients aren't as big of a fan of them. So case number 3, we'll move on to the next case. This was a 9-year-old who presented with 3 or 4 weeks of left knee pain, and the pain was activity related. And he wasn't having any kind of locking or catching, but he was having swelling. And in this case, the parent was noticing it too, that yes, sometimes after activity, it really did look different from the other knee, and it was fairly apparent. So, and when you do your physical exam, you note that he has mild effusion, and he also has is tender over the medial femoral condyle and the anteromedial joint line. So here's a picture of the medial aspect of the knee, and 1 is the joint line. And then from 2 to 3 is the medial collateral ligament. It actually goes down further than this, but this is just sort of its course. And then here we have the pes anserine bursa. And adults are much more likely to get a bursitis than a child. So that's a much less common problem. We wouldn't expect that in a 9-year-old. And so for this child, we got AP and lateral radiographs, and these were essentially normal. But we also got an additional view here. This is called a notch view. This is a view taken with the knee bent. And so if you think about it, if you've got your femur sitting on your tibia and you bend the femur, the x-rays will catch the back part of the femoral condyles better if you bend the knee. And so if you look closely here, there was a finding on this x-ray. And now I put my nice red arrow on it. You see it almost looks like a mouse took a little bite out of that condyle. So the joint surface here is not normal. And so the diagnosis here is this is a juvenile osteochondritis dissecans. And people may be less familiar with this diagnosis. Juvenile osteochondritis dissecans, what happens is that a little bit of the bone at the joint surface loses its blood supply and dies. And my analogy that I always use is that if you cut the stem of a flower, so if you go pick flowers, the instant that you separate the flower from its root, you cut it, the flower has died. And this is something I always argue with my partner, who says once the flowers have wilted, look, the flowers died. Whereas I say, nope, they died the minute that they were cut, because once you detach them from their roots, they're dead. And that's what happens with juvenile osteochondritis dissecans, is that the bone loses its blood supply, and initially it will look normal. At the instant the blood supply is lost, but then over time the bone will degrade, it dies, and then it regrows. And actually, as it turns out, it's just fine for the bone, but the issue is that if that piece of dead bone loosens, it will take the cartilage over the top at the joint surface with it. So it can sort of loosen from its spot and fall out. And if it takes its overlying cartilage with it or shifts the cartilage, that can lead to permanent arthritis or damage to the knee. So this is analogous to other problems where we see it's a type of avascular necrosis in a way, like Perthes disease is another example. There's a condition in one of the bones of the foot known as Feinberg's infraction, and another one in the foot, also Kohler disease. So there's other things like this where the bone loses its blood supply in children. And here's a picture of this on MRI. So this is these are T1 weighted images that highlight bone, and you can see this sort of really charcoal gray of this unhealthy bone in this spot. So what do we do for these? Well, this was a younger child, a 9-year-old, and luckily younger children tend to do better with these because they have a thicker layer of cartilage over the bone, is the thought. But we describe them as stable, as if that we actually get an MRI to make sure that the piece looks like it's not going to fall out. And if it looks stable and the child's not having mechanical symptoms, then we have them rest from activities for a minimum of 6 weeks, but usually 3 months. We often will immobilize them for the first 6 weeks and keep them out of impact activities, and then gradually reintroduce activities as long as the x-rays are improving and the child's symptoms are improving. But if they're unstable, meaning the piece looks like it's going to loosen, or if after 3 to 6 months the child is not getting better, or certainly if they're worsening, then we refer them for surgical management, which can involve drilling little holes into the piece to try and increase the blood supply, or putting a screw in the piece if it's coming out. Those are the most common surgeries. So I think I have time. Let's see, I'm checking. I think I'll do one more quick case. This is a 14-year-old football player with a 4-month history of bilateral knee pain, and he was seen by his primary care physician after a month and diagnosed with a muscle strain, and now he's got increased pain, and it's actually worse on the right than the left. And he really, even though he says knee, when he shows you where his pain is, it's really more over the distal thigh. And so on exam, this patient, he has a BMI of 33. He's unable to ambulate. His knee exam is completely unremarkable. It's normal. And when you put him and have him roll over into a prone position, he is unable to rotate his right hip in internal rotation. So we call that obligate external rotation. And he has minimal rotation of the left hip as well. And so this is just an important pearl in P to say that when you're examining a joint, for joint pain, you want to look at the joint above and the joint below, and that holds especially true if you're thinking about the anterior knee pain or thigh pain, is often referred pain from the hip. This says full symmetric hip range of motion. That's a mistake. This is, as I showed on my previous slide, this athlete had poor internal rotation. And so I show these x-rays. I think these are pretty obvious. He actually had a very obvious right skiffy, a slip capital-femoral epiphysis. And actually, he was starting to slip a little bit on the left as well. So this was like an early, fairly severe skiffy on the right and an early slip on the left as well. So, and there's just a close-up of that. So, and as probably people are aware, this is the proximal femoral epiphysis displaces relative to the metaphysis, and this happens from shear stress on a vulnerable physis in early adolescence. And remember that about 85% of patients who have skiffy are overweight or obese, but that means that 15% are not. So you want to just, even if it's not an obese patient, have this in your differential diagnosis. So I would say in sports medicine, not only do we get to show pictures of our kids and our pets, but also our favorite sports teams. So I'll end there, and I'm happy to take any questions.
That was absolutely great, Dr. Carl. Thank you for that. Your love for teaching has really come through in your presentation here. So I'm sure most of us really appreciate that, what you've gone through, especially with your films there. So, but we do have some questions in the chat room. But before I get to that, I just want to acknowledge all of the physical therapists that have joined us this afternoon. And then we have some repeat customers from this morning's that are online today. So I want to give you all a chance to go ahead and type up some questions in the chat room, because I know there's going to be many here. So, but first I'm going to start off from Julie. She says, for patients with chronic knee and pain need to refer out, do you prefer patients to visit with their images, or will you do that in the exam?
Yeah, well, my preference is to have patients, if they need x-rays, have them done with us, because we do pick certain x-ray views depending on what we see clinically. So sometimes patients will come to see us and we decide, oh, they had this set of x-rays, but we need a couple more. So that means 2 trips to the x-ray suite. That being said, if patients have x-rays, we love for them to bring them on a disc, because then we can, of course, avoid the need to repeat those and have them have extra charge. And also, the radiation exposure, as people know, is minimal for x-rays, but still nice to avoid a little extra.
Great. And then Anna asked, what would be the medical management for that last case?
Oh, for skiffy would be actually surgical management of, so the sort of classic, the classic surgery for skiffy is to put in these, basically it's screws, I should say, that go through the metaphysis into the epiphysis. That being said, for kids who have severe slips, there are some more complex acetabular surgeries. Jay Janicki is one of my colleagues, and within our group, we all have sort of our little niches that we like. And so Jay is an expert in reconstructive hip surgery. And so we now have a lot of kids who are getting larger surgeries for skiffy. And that sounds like it would be a bad thing, but the good thing is that if it's managed, if that is done early, then children are less likely to have future hip problems from their SCFE going into adulthood. So, so it's been great having Jay as a resource for patients. So I would say my management is to call Jay and say, Jay, I need your help.
Well, thank you for that. Everyone's doing great here, sending in a bunch of questions into the chat room to me. So I'm just going to keep firing away. One of these questions have been asked a few times today, so I'm going to get your take on it. So, as you know, kids are slowly getting back to school and playing sports. Really, a lot in the suburbs is going on. So, can we get your take on getting back to sports and how to, especially for these kids who haven't played for almost a year, any advice that you could send out to the pediatricians and to your physical therapists out there on how to take it slow and just overall advice on getting back to sports right now?
Yeah. Well, one is, I mean, honestly, our physical therapists have been our best partners in getting people back to activity gradually. I mean, the joke in sports medicine is that if when we look at it, it's usually because of good physical therapists. So we appreciate everything that you do for our patients. I would say that really the key is to go back to sports gradually, because we tend to see patients who are having an injury, and so they need to return gradually after an injury. But I think people don't think of it, children especially, they're so eager to get back to their sports that they want to just go full throttle. But we have been seeing a lot more overuse injuries where I actually saw it more in the fall, I feel like, a little bit less now because so many things were closed. So many of the indoor venues were closed down, and even some are still closed down. But we were just seeing lots of stress fractures and tendinopathy and things from just running, going back into sports too quickly, especially impact activity like running. That was the other thing, is aside from returning too quickly, many young athletes they're doing activity that they might not normally do to stay in shape. So maybe the soccer team practices are closed, or hockey practice isn't going. So instead, the athletes are doing a lot of running to stay in shape, and maybe they're kids who haven't been big runners and they start running 40 miles a week right out of the gate. And we saw a bunch of stress fractures related to that. So I think if it's a sport you're not used to, be a little bit cautious about easing into it, and also just in general, go gradually.
KIP for Coaches would probably be a really good asset to them as well.
Yeah, KIP for Coaches is a great program. I mean, we run, KIP is our knee injury prevention program, for that not familiar, and we run it in a couple different ways. One is that we run camps for the girls, and we do in-person training for the coaches. And those we've had less over because of COVID. But to me, I love our online KIP for Coaches. It's basically a little online module a KIP could do to learn warm-ups. And a lot of coaches tell us, I knew most stuff in there, but I never really put it together in this. Like, we've used some of those exercises occasionally, but I've never seen it put together in this way. And so it's just a way to really standardize the workout, the warm-up, and it's been shown to reduce knee injuries, and it involves a lot of core strengthening activities. Some of the activities like all the kids hate them, but they're really good for core strengthening. And it's not only does it prevent injuries, but it probably boosts performance in these kids as well. So I think that is a great program. And I know a lot of we work with such great youth coaches, but a lot of them that are at a loss of sort of how to gradually reintroduce kids into sports. So
right,
it's a great. If you ask most of the people in sports medicine, we've all done the exercises ourselves or had our
right. I don't like doing plyometrics myself. So Erica Diane, she asks a question. Do you have any other knee exam pearls tips on adjusting for knee stability?
Yeah, so it's a little harder, unfortunately, in the online module. It's a little harder to do the maneuvers. Also, I didn't cover ACL injuries because Niraj Patel, my colleague, is going to cover those later. But I do have some tips that I like for looking at ligament. Actually, one that I'd like to share is that one exam maneuver that I found really difficult for people to learn is the McMurray test for the knee. So for people familiar, the McMurray test is to look at meniscal injuries in the knee, and it involves fully flexing the knee, rotating the tibia, straightening out the knee, and applying valgus or varus forces. It's a lot of steps, and it actually is not a test that's been shown to be really sensitive in the literature. So I actually really like another test for looking at meniscus. This isn't really stability, but meniscal injuries, and that's called the Thessaly test, and it's a super easy test to do. And I hopefully people can see me in the little tiny square, but I'll just demonstrate it. But what it involves, let me just adjust my screen a little. It's basically just having a patient flex their knee a little bit and then rotating at the hips, sort of doing the twist. And what you do when you do that is you're actually you're doing you're axially loading the knee joint, and it's a great way to stress the meniscus. And it's so easy to learn. You know, our residents and students love it because they don't see tons of sports medicine, and so when they go off and do something else, much easier than remembering all the steps of McMurray. So that's one tip. And then another one is that when I'm doing ligament stability maneuvers, I also like to I actually will put my knee up on the table, and then I'll have the patient use my knee as sort of like a stand for their knee. So if they're laying on their backs and I put my knee up on the table and they use that to they just basically sort of drape their knee over mine. And then that lets the patient relax really nicely, and it also puts them in a perfect slight bend for doing tests like testing the lateral and medial collateral ligaments and doing the Lockman test to look at the ACL. And I find often when you tell patients, relax, 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 the more you say relax and you're holding up their knee, on their knee, they're like tensing up their muscles. And so if I find if I've got draped over my knee and then I'm making conversation, that I can just sort of slide in there and real quick do my Lockman maneuver and check their ligaments.
You know, so we're approaching 1 o'clock now, and are you able to stay on for a few more minutes to ask some more questions? Okay.
And also I totally will have to get back to their clinical work too, so won't hurt my feelings.
Yeah, we got like 3 questions left, and just to remind everybody, this is being recorded so we can send this out as well. So in juvenile OD, roughly how long do you see duration of pain symptoms before kids present? More acute or developing more chronically?
Yeah, that's a great question. You know, it really depends. I mean, I think I've really seen the gamut. It's a diagnosis where often we have kids who have been seen previously. So they've like gone to see somebody and maybe they went to an urgent care and the urgent care got an AP and lateral x-ray and it was normal and they said, you're fine, go back to activity. So I do feel like because people aren't aware that they need to get that bent knee view, a lot of these get missed. And so it's kind of like we see that some patients who present right away and then others who they've been dealing with it chronically. I remember I have one patient who had just a horrible OCD, and she played on it for 6 months because she saw somebody who never who didn't get a notch view, and so she ended up having by the time she came to see us, it was a pretty serious situation with her knee. I mean, she was fortunately seen by one of our surgeons and I think did okay, but it would have been better if she was caught 6 months earlier. So I think of these as being it's kind of like at 2 poles. Some kids come in and they see us when they have pain and we pick it up and pull them out of activity. And then we have other kids where they come in later. And it's really, I mean, there was a study that was done, it was in kids, and they asked kids to rank being cut from a sports team, comparing it to other life events, and kids rated it with like their best friend moving away and their parents getting divorced. I mean, kids are just like so distraught when that was getting cut from a team, but when they miss sports. So OCD is a really tough diagnosis. We're often keeping kids, it's one of the few things where we're saying to kids, you're out for, several months. And they're like, what does that mean? Like, does that mean like I can't do tournaments? And we're like, no. Like you're off the knee for a little while. And the parents are usually calling us before the time is done to be like, no, you don't understand. He's got to get back to activity. She's got to go back to soccer.
Right. I know how that goes as a parent of sports of athletes. You did bring up immediate care, so I want to throw up this slide. We do have immediate care center in both Northbrook and in Chicago. And if you have patients that are injured, and it's a weekend and your offices are closed, we are here for you in Northbrook and Lincoln Park. It's a supplement to help you guys take care of your patients, and it gives you direct access into our sports med team too. So it's a very useful and helpful service that we have to offer. So speaking of locations, what are the locations you're at? So you're going to be at Skokie, Lincoln Park, Northbrook, and Westchester. Is there anywhere else you see patients? And do you have physical therapy that you or therapists that we work with?
Yeah, well, we have physical therapy in our of all those centers. They all actually have Lurie physical therapists. But for so many of our patients, we're often referring people to outside physical therapists. And I know many of you who are online here, we've probably shared patients. But just because if a patient doesn't, often it's not a perfect match in terms of location or timing available. So we can help when we have when we have patients who have a therapist that they've seen and that they know and like, we have them go back to see that person. And then we also, have patients see therapists that we've worked with even outside of Lurie. So.
Great. I'm going to get through these last two questions and we can wrap it up. Is there anything that comes to mind in families where multiple members have repeated significant injuries, such as multiple ACL tears, bicep tendon tears, thoughts other than EDS or Marfan's? I'm going to guess meds or Marfan's. EDs or Marfan's.
Yeah, Ehlers-Danlos is EDS. So yeah, certainly hypermobility. There is, Ehlers-Danlos, the hypermobility type, is also, sort of in the spectrum of generalized hypermobility, and certainly that does increase people's risk of ligament injuries. And then we also think about certainly bony injuries. We would think about either something more systemic, low bone density. Sometimes that can run in. There are certain well-known genetic conditions like osteogenesis imperfecta, where kids can have frequent fractures, but also there's kids who have low bone density. So we have a bone health clinic, and if we have kids who have certain kinds of injuries, we'll sometimes send them for additional medical workup through our bone health clinic. It's hard. There are things that run in OCD can run in families. It just sort of depends on it's a great question, but it's also sort of an involved one depending on what the injuries are. But I think definitely that there are other familial issues that can come up when we have kids who have other injuries in the family.
Okay, and then do you have other clinical pearls you suggest specifically to potentially rule in OCD in the clinic?
Yeah, so it's interesting because there is a test that's designed. It's called Wilson maneuver, and it was described by Dr. Wilson, who he intended that to be used for OCD. And what the test is that you have the patients laying on their backs with their hip flexed to 90 degrees, their knee flexed to 90 degrees, and then you rotate. I'm gonna see if I can do it. I don't know if I can. So you've got. I don't know if on this I can, but.
Yeah, we can see it.
Rotate the tibia out and straighten the knee, and when that elicits pain or catching, that's thought to be indicative of a positive for OCD. And that test it hasn't been tested very well in the research. That would actually be a great research project, is to start using that routinely and look at the sensitivity and specificity, because it hasn't been done in a while. But it does not it's not a great predictor of the presence of OCD. I'll tell you the things that worry me. I mean, certainly any history of catching or locking of the knee, swelling without an injury makes me think of rheumatologic things like juvenile arthritis, but also OCD. And also if they have pain kind of over the the kids tend to have some pain over the anteromedial or anterolateral joint line, depending on where their lesion is. So those are things. I'll say this, is that if I have a patient where they're describing kind of vague activity-related knee pain, but I can't really get my head or my hands around it in the clinic, and I'm not sure what it is, I'm more likely to get x-rays to look for OCD. It's kind of this thing, I feel like it's like hanging out over my shoulder. Am I missing an OCD? So often when I get x-rays, and it's because, gosh, I don't, this kid's having a lot of pain with activity, but I am not seeing anything on exam about their strength or their alignment or their their ligament stability, or there's nothing that I can put my finger on in the exam. That's a scenario where I'm often getting a series of x-rays that includes AP lateral and a notch view to make sure that I'm not missing an OCD. So it's a good question, but I will say it's something that can sometimes be hard to get to pin down just with physical exam.
Well, I'll say this has been a great session. And if any of you want to reach out to me and try to schedule another session with Dr. Carl, we can do so. We love setting up meetings for our specialists, because the more you learn, the better we all are. So, but I want to thank everybody for joining us today. And to reach Dr. Carl, you can reach her at 312-227-6190, or you can email her at rcarl@luriechildrens.org. And if you're able to, we have, and you can do a rapid connect or Epic in basket. You can do that as well. And the one thing I wanted to bring up that I haven't in the other sessions today that I'm remiss is that we do have Lurie MD that you can call in. It's a dedicated line, 4 physicians, 2 physicians, at 1-855-Lurie MD, and that would be 587-4363. And you can, they will triage you to our sports medicine team for those questions as well. But other than that, we'd like to thank you today for joining us, and I encourage you to join us for Dr. Greg Finlayson at 3 o'clock for that meeting today. So we'll see you at 3 o'clock, everybody, and have a great afternoon. Thank you, Dr. Carl. Anything you want to say before we leave?
No, Craig's a great speaker, though. I always love his talk, so I wish I could. But
All right. Well, thank you, everybody, and have a great day.
Thanks so much.